competitors?
Well, I thought I was going to have to do the introducing.
Well, I'll erase the board.
Yeah, I'm going to use the board,
Yeah,
so I apologize to touch.
It's okay.
Cassidy, maybe. I'm pretty sure the artist that did that can go all out again. You know, interesting, I went into the restroom and there has like a sign that says, please flush to help control odor. I'm like, really? Did people in this building have to be reminded about that? Science and math? Anyway, so, you know, I work at the Baptist Medical Center. I've been there for 6 months. Previously, I worked at Norman with somebody that I know here, or somebody significant other that I know here. I was there for 2.5 years, and now I've been at Baptist for almost 6 months. So I'm fortunate to be there just because I get to see a lot higher complexity patients there, and not only that, you know, we have a huge transplant, you know, liver, heart, pancreas transplant center. I don't work in a transplant center. I'm a hospitalist. I'm not a hepatologist. We do admit a lot of the cirrhosis patients because I guess the transplant people think they're above us and too lazy to admit them. I don't know. You know, whatever. Better for me, more experience, right? So, you know, my name is Professor Rourke. Let me use her PowerPoint, so I'm going to go ahead and use on my. So here we have some interesting facts. Excuse me, the learning objectives. I guess we used to get learning objectives. I don't know if they ever correlated with the test or not, honestly. I was just like, I started at a study guide and I've never reviewed the learning objectives, so maybe you one of those students and more power to you. Okay. And here we have some interesting facts about you know, if you're out in trivia and at a restaurant and want to sound really smart, you know, or they happen to ask you. You know, the thing that caught my attention about this slide is, unfortunately, there is no cure for cirrhosis other than transplant. So, you know, what we're doing for patients is just patching them up, and hopefully, they can get a transplant. It's really frustrating clinically, telling this to patients. You know, that why am I not getting better? They keep asking, and they have all these symptoms, and and sometimes even though patients know, it takes them a while to understand, you know, and it could be, you know, challenging when dealing with a patient that doesn't really have a cure, and a lot of them, you know, are on the waiting list for a long time. I just had a patient that's been on the waiting list for 3 years, and she's been in and out of the hospital for the last 6 months from complications of cirrhosis, and it's frustrating for them, especially for the family. You know, they're like, we're doing everything right. You know, we're taking our lactulose, we're doing the fluid restriction, and she's still in and out of the hospital, you know, and it's like, you know, I understand your frustration, and hopefully she can get a transplant soon. And the liver is also a fascinating organ, you know, the liver does well up until 10%, you know, so that's pretty interesting. So what is the liver cirrhosis? You know, liver cirrhosis is liver disease, and it's a progressive disease. It just doesn't happen overnight, you know. So we have it's fibrosis, scarring, leading to regenerative nodules. That comes from chronic liver inflammation, you know, and it's a stepwise process. Like we have here a picture of a healthy liver progressing to a fatty liver. Fatty liver, we'll talk about this later. Very common cause of cirrhosis here in the U.S., and there's 2 types of fatty liver. If you look at it that way, alcoholic and non-alcoholic are the 2 most prevalent. So, and then when it's gone too far, unfortunately, there's no going back. When you're in the fatty liver stage, if you modify the offending agent or offending things, you can always go back. But once you go to cirrhosis, to this last, to the very right, unfortunately, that's it. You know, it's too late. Here we have some more, you know, epidemiology of the cirrhosis. It might not look like that many. 1%, you know, in the U.S., 27%, less than 1%. But I see quite a bit of cirrhotic patients, you know, and then what got my attention on this slide is how it's a high prevalence on people with poverty. You know, I think in low education, you know, thinking back on it or doing some thinking, I was like, why? You know, probably people with poverty and lower education, they probably have poor ways of coping with their, you know, anxiety, maybe depression, maybe they self-medicate, take alcohol to, you know, deal with their anxieties and depression. They also might not have, you know, the best education on what a good diet is, etc. There's also a correlation between, you know, lower education and poverty and obesity and metabolic syndrome. So we see now that obesity is not, it was once thought that, you know, it was a problem of, oh, you're just lazy, don't like to work out, you know. But now we know it's a multifactorial disease process that causes a lot of problems. And so make sure when you see patients, you should be documenting that on your, you know, assessment, obesity, morbid obesity. Now we see, you know, we're correlating a lot of disease problems with these people. So that's it. And then also, I'm Mexican, so, you know, of course, Mexican Americans, you know, we like to party, we like to, we like to drink a lot, so probably that's why, you know. All right, so here we have some, you know, some common causes of cirrhosis, or the most common causes. So chronic hepatitis C, you know, it's debatable if that's the most common or alcoholic. I don't think it really matters. It's just the point, you know. The point is it's very common, maybe the most common. So I'm going to use this. I'm going to do a little old school. I don't know. See how it works out. So just to mention, these are hepatocytes. So we're going to focus on one of the hepatocytes, and you have a. So hepatitis C is a virus. It comes and it attaches to the cell. So I'm gonna try to go over some basic physiology, biochemistry, you know, just to prove a point. I'm not a physiologist, I'm not a biochemist, so if anybody in here is, I'm not gonna go into every single, you know, chemical reaction and whatever, you know. So the virus comes and attaches, it releases the viral DNA, you know, takes over the cell. The cell is like, what's going on? You know, this is not normal. You know, so then the hepatocyte puts a protein up here, the MHC1, and that'll signal the immune system, hey, there's something going on, you know, something's not right, can you help me out? So then we have, you know, this is the Cd8 Lymphocytes, which is a part of your immune system. They'll come and they'll attach, right? And they'll recognize this signal and they'll process it, and then they'll say, well, you know, this cell's not good anymore. So then they'll send a signal to the cell, and the cell will go into apoptosis, or will die, you know? So it's dead. You know? So, you know, leading up to this, it'll be inflammation and the cell trying to figure out what's going on, and eventually it'll lead to cell death, you know. So now we have alcohol liver disease. So this is one of the fatty liver. If you look at fatty liver, it'll be alcohol and non-alcoholic. I thought Professor Roque talked to you guys about the non-alcoholic. So, in alcohol liver cirrhosis, looking at the hepatocyte, you know, so here we have me on the weekend. Have you guys seen like the 3-liter tequila bottles? Why can't I get some here? Yeah. So then you ingest this, you know, and it goes down to your stomach, and then I've been practicing how to draw a liver, so you guys are going to use a lot of imagination here. And then from your, you know, in small amounts your body can process alcohol, no problem, but in large amounts is where the problem is. So then it goes to your liver, and then we're zooming in here, we're here, now we're at the hepatocyte. So then alcohol comes in, you know, there's three main, in the hepatocyte there's three main reactions, or it goes through three processes to get processed. So we have alcohol dehydrogenase, and then we have the CYP 450 E1 to something like that, and then we have catalase and peroxisomes, you know, and then we get acetaldehyde from this. Right. This are, you know, this is a peroxisome. This is a group of enzymes, the CYP40. You hear about that with a lot of medications. You know, it's a group of enzymes that help process and manage foreign objects or foreign chemicals in your body, mostly that are toxic. And then I'm sure you guys heard about alcohol dehydrogenase, and then the catalase and the peroxisomes. So this is the, once we get, so let's talk about this process where it gets processed through the alcohol dehydrogenase. And you know, in this reaction, there's a lot of NAD and ADH to ADH plus conversion. You know, so this will be increasing, more alcohol, right? And this will be decreasing. So whenever there's NAD plus decreasing, that signals the cell for less oxidation of free fatty acids. And whenever it goes to NAD plus and NADH, this signals the cell to store more free fatty acids. So what you end up having is an accumulation, you know, just imagine this is fat, an accumulation of fat inside the hepatocytes. You know, and then we'll talk about why having fat accumulation in the hepatocyte leads to inflammation and scarring. So then it pushes the nuclei to the end. Okay, so this is one way you get fatty acids in the hepatocyte. And not only that, going through this process, you have to worry about acetaldehyde. What is acetaldehyde doing? Acetaldehyde is reacting with proteins inside the cell, nucleic acids, other proteins, macromolecules. So it binds to the macromolecules, and this itself, you know, gets put on the surface of the of the cell. And this signals to the immune system as well. So that'll lead to inflammation. Okay? I'm missing a step, but I can't remember right now what I said there. Oh, and also we have reactive oxygen species. You know, you always hear about reactive oxygen species. This are, you know, byproduct of aerobic respiration. You know, the reactive oxygen species are like only active for like 1 to the -9, like a nanosecond, which in our lives is nothing, right? But in a molecular cellular life is long enough to cause reaction. So that's how, and so let's talk about, so then we can talk about the inflammation, why there's inflammation caused by the fatty liver. When we talk, once you have fat storage, this is the way that we have fat storage with alcohol. Now let's talk about fatty liver, or non-alcoholic fatty liver. So non-alcoholic fatty liver, as probably Professor wrote for you, is a spectrum of disease where you have steatosis, then steatohepatitis, and then some scarring, and then you have cirrhosis, you know. And this is mostly seen in people with metabolic syndrome, people with obesity, hypertension, diabetes, hyperlipidemia, hypertriglyceridemia. If you have 3 out of 5, then you're considered to have metabolic syndrome, along with, you know, waist, if you're a male, waistline of 40 inches, and female would be 37. So what happens in the hepatocyte? So here we have here we have a fatty acid. You know, this is a conjugated fatty acid because it has, excuse me, not a conjugated, I'm thinking about bilirubin. A saturated fatty acid because it has a double bond. This makes a good, this hydroxyl group makes a good place for it to react with reactive oxygen species. So if you're already drinking alcohol, you know, that's causing reactive oxygen species. On top of that, you have a bad diet. So it'll, you know, the common reactive oxygen species. And then this one's negative. So this one's the worst. So you have one of this. So let's say you have this. Now we're going to some organic chemistry, right? You guys thought you got it away from it, right? So it'll make some water plus so that once you go here to once it reacts, you have a fatty acid that's reactive with a reactive oxygen species that can go and react with lipid membranes and even nucleic acid, the DNA. It'll change the hepatocyte and it'll make it inflammation. Eventually the hepatocyte will die off. So that's how. And then hepatitis B, you know, kind of the same idea with the hepatitis C. And there's other causes of cirrhosis, drug-induced, some genetic causes. We won't go too much into that. We'll stay focused on the most common causes. People usually, you know, when you come in, when you have a patient that comes in and has a fancy diagnosis, you know, it kind of makes you feel like a bad clinician, like, oh, how come I don't ever find this stuff? But these are people that usually have workups for years. You know, that's something wrong over and over. They go to their primary care, they end up in cardiology, nothing cardiology can find, they end up in pulmonology, nothing pulmonology can find, and then they end up in some random specialty. They'll find a random, you know, diagnosis after running millions of tests. So don't ever feel bad if you don't ever make a, you know, fancy diagnosis, or if you don't find a field cytochrome or whatever they'll call. It'll be exciting to find one, but so we have the risk factors. We talked about the risk factors: alcohol abuse, IV drug abuse, because, you know, hepatitis C is transferred via the blood. It's transferred by IV drugs, childbirth, or sexual intercourse, as well as hepatitis C, obesity. So I guess we didn't really talk about how cirrhosis, you know, we talked about what, you know, leads to the hepatocyte death, right? And therefore leading to cirrhosis. So let's talk about what is it about the hepatocyte death that leads, causes the scarring and inflammation in the liver. So this is the picture that I wanted to start off on, but I don't know why I deviated from this. So here we have and you know, it's mediated by cells called stellate cells located in the parasynoid space in the liver. So once again we're zooming in the liver. This is a hepatocyte. Here we have the bile duct. This is the parasynoid space. And this is a sign. I don't even know how I'm spelling it right. So we have a stellate cell here, minding its own business. We all like stuff that minds its own business. Usually, has basic function like storing vitamin A. For the most part, really doesn't do much. Then we have, when the hepatocytes are working, there's no problem. But then we already talked about how the hepatocytes die, right? So then, for whatever reason, this hepatocyte is dead. Then it signals the stellate cells to kind of kick in and start producing collagen. So it'll produce a lot of collagen, to the point where it's pushing up against the sinusoid. So the sinusoid is, let's talk about the blood flow to the liver. The liver is a unique organ. It has blood source from two places. The hepatic artery, which is straight from the heart, oxygenated blood. And then it also gets blood from the portal system, which is deoxygenated blood with nutrients. So we have the hepatic artery, and then we have the portal vein. We're zooming in, right? So, the hepatic artery and then the portal vein, they come in and make inside the liver, and they come in and make a sinusoid. So going back to the stellate cell produces a lot of collagen. It starts pushing in on this sinusoid, right? So this is an important point because this is where you can have portal hypertension. This is why. You have the pushing up. Because this, of course, the portal vein and the hepatic artery is draining into this. So this is an important point. And then on this slide, like we talked about, 80% of chronic liver disease is preventable because, you can obviously stop drinking. You can obviously modify your diet. So you can take precautions, have safe sex, or not use IV drugs to try to prevent hepatitis C or hepatitis B from being transmitted. All right, let's talk about alcohol. This is, I don't know, I guess it's good for clinicians to know. Patients are not going to tell you, hey, I drink 45.5 ounces a day, How much do you drink? I don't know, 3 to 6 beers, and then you'll have the ones that say, oh, I have a cocktail, and then, or the ones that say, oh, I have a red wine a day, and then you have to ask them how big their glass is, because they don't quantify. In the hospital, when I was a student, I was like, what's the big deal with social history? Like, why do we even get social history? Who cares, This is one of the reasons why, because you don't want patients to go into withdrawal. So you want to ask patients how much to drink and if they drink every day. And then the next question that I always ask is, hey, if you don't drink, do you get the shakes? And at first, when I first started asking that question, I was like, man, that kind of sounds rude, but it is what it is. Most patients know they have a problem and they drink, and trust me, they know if they get the shakes. So you better be asking, hey, just let me know if you have the shakes, that way we can put you on something. Because last thing you want them to you want them to come in for the compensated cirrhosis, and they end up in the ICU with status epilepticus from alcohol withdrawal. So this is just complication. Typically, I put my patients that do drink every day, like I said, it's hard, you would want to be scientific and evidence-based and document, hey, they drink, 15 fluid ounces of wine a night. But typically, if they drink every day, of course, if they tell me they get the shakes, and if they drink, more than 2 or 3 drinks or whatever, standard drinks, 12 fluid ounces of beer, if they drink 3 or more, or if they drink, 2, for men, if they drink 3 cocktails a night, every night, and if they've been doing it for 10 years, then I usually put them on, Librium, 25 milligrams TID, which is just a long-acting benzodiazepine, and then we put them on IV, on Ativan, IV Ativan PRN for withdrawals. Ideally, you would want to send these patients home with Librium for a couple weeks, and hopefully it would wean off the alcohol. Unfortunately, more likely than not, they go back to the same environment. You sit on the same couch, watching the same TV show, hanging out with the same people. You're probably going to go back and do the same things you were doing, like drinking. So just be aware that, even though you tell them, hey, don't go home and drink with this Librium, they might go ahead and do it anyways. So, and it's hard to assess patients. Some of them will just tell you straight up. You'll be surprised how honest patients are, And some of them will just tell you, you know what, I'm not ready to drink. I'm not ready to quit. I'm not going to quit drinking. So, fair enough. I won't send you home with Librium. Go keep drinking your vodka, because then if you take the Librium and the vodka, and then you end up driving, and that's probably not going to be good. And then don't ever hesitate to ask patients. Like whenever I first graduated, I graduated in 2014, so I'm relatively new by now. I've seen what I'm going to see. I might see some rare case, every now and then. Like the other day I saw septic emboli in the lungs, which I've never seen. And I had to talk to my attending about it. Apparently it's not a blood clot with infection in it. It's just an infection. So it's just a ball of whatever, staph. For the sake of teaching, it's just a ball of staph from a source that dislodges and ends up in the lung. So you don't have to put them on anticoagulation and antibiotics. Antibiotics will take care of it. I don't think I followed up on that patient. I typically try to follow up on patients, especially if there's other consultants like infectious disease, to see what they're thinking. That's the great thing about working in the hospital. You stay up to date with every specialty, especially myself, that we're the hospitalist, and we consult on just about every specialty. When you see something rare, or you can always follow up on patients, see what the other specialties are doing or what they're recommending. It really helps you stay up to date, and it's kind of fun, And it's also kind of fun seeing what you're doing wrong, And it's heartbreaking when you are doing something wrong, but at least, because let's say you go work in a clinic somewhere, I don't know, primary care. Nobody's really going to tell you, hey, you're doing something wrong. You're really not getting any peer feedback, from other specialties. So unless you're really up to date to where you're reading your articles that the AAPA sends you every month or something. Okay, so moving on. So we talked about alcohol already. There's controversy about, I think they updated the new guidelines. 4 drinks sounds like a lot. I think it's 2 drinks. I don't know. I think it's 2 drinks now for men and 1 for female. Yeah. The 14 part sounds about right. No, that's right. Yeah, 4 drinks a day or 14 drinks per week. Yeah. So that if it's 14 drinks per week, that'll be 2 drinks a day. Yeah. Yeah, if you drink 4 drinks at once, depending where you get it at, you'll be having a good time. So here we have, like I talked about, the progression of of the liver disease. Eventually, I think it's like 20 to 30% of people end up with hepatocellular carcinoma from cirrhosis. You know, this is because of the continuous hepatocytes. They keep regenerating, and it leads to uncontrolled regeneration that leads to cancer, which, you know, that's what cancer is, right? It's uncontrolled regeneration of cells. So, unfortunately, when it's gone that far, it's too late. So it's important to know about the things that we talked about, how to prevent F to get it from there. So we'll talk about, let's talk about some changes or some, you know, what cirrhosis causes. So let's talk about bile. Let's see who does a better job, myself or Dr. McNeil with this famous bilirubin. I got some big shoes to fill, huh? I remember getting that lecture, and I was like, man, that's so fascinating, but as soon as I walked out the room, I forgot. Darn.
And it is the exact same lecture.
Well, I guess it's the exact same process, you know.
It is, that's the process.
Human. So then we have, you know, the bone marrow. Whoa, that's not. Sorry. So we have the bone marrow, right? This makes erythrocytes, you know, and then they're alive for 120 days. For a healthy human, right? We have people that have sickle cell, you know. This is a important concept to understand that, you know, it's 120 days, and some people with some genetic problems might have shorter life on red blood cells, you know. So what happens is the red blood cell circulates for 120 days. It gets old. It's not good anymore. Then we have macrophages that eat this. I was trying to draw them out, but you know, eat it. And then they take it to the spleen. I guess the spleen is like a ball. So from the spleen, you know, it takes the red blood cell and it breaks it down. The spleen breaks it down to globin. And that is further broken down to amino acids. And that is recycled. The amino acids are recycled back to the bone marrow to make more red blood cells. And then it's broken down to heme, to globin and heme. And then furthermore, heme is broken down to iron and bilirubin. More importantly, unconjugated bilirubin. Whatever. So the iron is recycled back to the bone marrow to make more red blood cells. Right? It's fascinating how our body, you know, it does its things. It recycles things. It doesn't, you know, necessarily throw them away. So then we have unconjugated bilirubin. Unconjugated bilirubin is fat soluble. They always make a big deal out of it. Fat soluble. You know, they make a big deal for a reason, right? So then the unconjugated bilirubin is fat soluble, so it has to be transported in the blood by a protein, which is albumin. So it hops on albumin and is transported to the liver. Okay. So now we're swimming in the liver again, right? And here we have a hepatocyte. So then the unconjugated bilirubin comes in and gets processed by an enzyme, I think it's called UGT, which adds glucuronic acid and it makes it conjugated bilirubin. Okay? So now when it becomes conjugated bilirubin, it's water soluble, right? So now it can be sent to, and now it can be excreted in the excreted in the bile, and then once again, guys, use your imagination. It'll be excreted in the bile and stored in the gallbladder. Now when you eat, I don't know, what do you guys like to eat? Donuts? Pizza? I'll try to draw pizza. And it's a cheese crust. Then you eat this, right? And then now it gets secreted into the duodenum. So it comes in the duodenum, and it makes it all the way down to the end of the small intestine, the ileus, into the large intestine, and then in there, so we have conjugated bilirubin come in. Bacteria convert it to urobilinogen. And then, furthermore, we have an enzyme in there that converts it to stercobilin. I don't even know why I'm trying to write all this stuff in here. Stercobilin is excreted in the feces, and that's what gives it the feces brown color. And then about 10% of it gets reabsorbed back to the liver. Now the urobilinogen gets reabsorbed. And in the plasma, it gets converted. Some of it gets converted to urobilin, which is excreted in the kidney, and then that's about 5%. And then the other percent of urobilinogen gets reabsorbed again in the hepatic entero bili something cycle, which is just it goes. You guys can look it up. It goes over and over. So this is this is where patients with cirrhosis end up in trouble because this is where they get the yellowing of the skin and yellowing of the eyes. The first place you'll see it is in the eyes because apparently there's like elastin in your eyes and it has a high affinity for the bilirubin. My old attending said if you ever have to do a standardized physical exam, if they ask you to check for bilirubin, make sure you do it under sunlight because that's how you officially do it. You need to have sunlight, so in the room it's not good enough. But who has time to walk their patient outside when they're in for decompensated cirrhosis and then they end up with spontaneous bacterial peritonitis and now they have sepsis and they're laying in the bed like that. It's like, really, I'm going to roll this bed outside to see if you have. Anyway, so then you have a hepatocyte. So you can imagine when the unconjugated bilirubin comes in, the hepatocyte with the UGT. So if the hepatocyte is dead, that's mine. Should be so this is there no more. So the unconjugated bilirubin is leaked into circulation, and it cannot be excreted because it's not water soluble. So it can't be excreted by the feces or the urine. This is actually a fun pathway or an interesting pathway because then you have like genetic causes, like disorders like Gilbert's, I don't know how you define, where they have a downregulation of the UGT. And let's say typical for learning purposes, let's say a hepatocyte typically processes 10 or 5 unconjugated. You know, this is a healthy one. And this is, the UGT is downregulated. So now it can only process 3. So the extra 2 are leaked out, you know. There's Najar Kingler or Kingler Najar. That's the one where they don't have the GUT enzyme, so they have about a leak of unconjugated. So in cirrhosis, we see both conjugated and unconjugated bilirubin leaked out, because when the cell dies, it leaks out the conjugated bilirubin it had already transformed, right? Or processed. And on top of that, you have the unconjugated bilirubin that's being, it can't be processed, so it just leaks out. Let's see here. And then, you know, the liver is very important in making clotting factors. So don't ever be that PA that calls the hepatologist and tells them, hey, this patient has cirrhosis, but their liver enzymes are okay. Why? Well, because liver enzyme transaminases are more, they have to do more with the integrity of the cells. So whenever they, you know, AST, ALT, they're inside the hepatocyte. So whenever they die, the hepatocyte, they're leaked out. So if you don't have no more hepatocytes, if you have cirrhosis and you don't have no more hepatocytes, then how are you going to leak out AST, ALT? So don't do that. You know, a more important lab, or more, you know, if you want to prove a point of how bad the cirrhosis is, it's a PT INR. You know, you call them, you tell them, hey, this patient's INR is 2. I haven't seen a 2, but I'm pretty sure. Typically, I see around 1.5, 1.6. In a hepatologist world, that means a lot, you know, because they see tons of cirrhosis, you know, even more than I do. So they might even have like a better idea, and even they might even use the MELD, MELD score, which uses, you know, INR. So, and then we see thrombocytopenia. It's time to talk about the portal system, because this is why you get thrombocytopenia, is from elevation in the portal, pressure and the elevation in the portal vein. So remember in that when I drew first how there was collagen, and the collagen started pressing on the sinusoid, and the portal vein drains in the sinusoid. So you can have cirrhosis or scarring anywhere along the liver. So we have the liver. This is the portal vein. This is the portal vein. So what drains into the portal vein is your stomach, your liver, your small intestine, your large intestine, you know, transverse, descending, whatever. So as you can imagine, when the stomach vein drains into the portal vein, the spleen vein drains into there, blood from the intestines, mainly the superior mesenteric, inferior mesenteric veins drain in here. So when they drain, the blood can't get through, you know, because you'll have scarring, and the blood, it just can't get through. So then you have backing up of the it increases. So first it backs up, so then you have this backing up to the spleen, right? So then we have splenomegaly. That's how you get splenomegaly, right? And the spleen plays a big role in processing white blood cells, red blood cells, platelets, you know. So if the spleen is backed up, then it sends a signal to the bone marrow, hey, you're sending me too many cells for me to process. I can't do it, you know? So that's why you have a decreased platelet count, because then the bone marrow doesn't, you know, produce enough platelets. And this is important because we just talked about the PTINR, and if you have low blood platelets, and you have an elevated INR because you're not producing enough clotting factors. These patients are high risk for bleeds. And then it leads up to esophageal varices. You know, once again, the stomach vein is draining into the portal system, and it's backing up, and then you get esophageal varices, right? And, well, what's the big deal with esophageal varices? Well, they're very likely to bleed, you know. So, and then, so then we have the ascites. Albumin plays a big, is made in the liver, and it plays a big role, mostly, like we talked about, transporting bilirubin, also in the blood vessels, for the oncotic pressure to keep the fluid inside the blood vessels. These patients have a lot of fluid, and we'll talk about more about how they get ascites. It's just on the wrong space, you know. So let's talk about ascites. This patient's, the portal vein hypertension, when it gets to be so bad, the fluid starts backing up, and then you have increase in the capillaries, and it starts leaking out where it can. So what's a good place for it to leak out? In the peritoneal cavity, you know? So it leaks out there. On top of that, you know, you're not having blood stay in the vessels because of the albumin. The liver is not producing albumin. Which makes so there's not enough return to the heart to pump out, and then the blood that is being pumped out is being leaked out, not literally the blood, but the plasma or whatever is being leaked out because there's no albumin to keep it in the blood vessels. So this is a great recipe to have hepatorenal syndrome. So you guys can take a 10-minute break, and then when you come back, we can talk about some hepatorenal syndrome.